These days, as we live longer, as we live longer as elderly, frail people, as medical technology is better than it ever was at keeping us alive, in circumstances in which we may or may not really wish to be kept alive, we each of us need to think about that circumstance. And in particular, we need to think about the fact that now, when we're relatively young and healthy, when we go and see the doctor, we can talk to the doctor about how we're feeling, and we can talk to the doctor about our aches and pains, and the doctor can give us advice and suggest treatments, and we can really negotiate things. We can collaborate with the doctor. We can rely on the doctor's advice. We can take it in. We can think about it. We can come back and we can say, it's not going to work out because my family are going to be away. I don't think I'll like the side effects of that drug. We can talk about it. Now, what we need to realise is that there may well come a time where we need medical treatment, but in fact we're not able to have the conversation with the doctor that we now can have. So, what's going to happen there? Well, I suppose the very best thing is that the doctor is able to have the conversation with someone who knows us. Someone with whom the doctor can really think the matter over and think about what would be the best form of treatment or care in these particular circumstances, whatever they are. Now, if that's likely to happen, if it's likely to be the case that one day I will need medical treatment and care, but I won't be able to talk that over with the doctor, then if I'll need to rely on someone else having that conversation, what I should do now is to anticipate the fact that that will be hard for that person. They'll find that a real burden, because I'm likely to want it to be someone in my family. It's likely to be someone who loves me. If I'm in those circumstances where I'm older and frailer and maybe unconscious and I can't have the conversations, it's likely that that family member will be feeling under great strain. So now I should do something to help that person. So I suppose the very first thing I should do is to have a think about who is it that I would like the doctor to talk to? Who is it that I can trust to have the conversations with the doctor on my behalf? Who knows me? Who knows that I won't want heroics, that I will want to be conscious, as long as I possibly can, that I'm a real wimp when it comes to pain. Who is that? And I guess in my own case it'll be someone in my own family. Whoever I might think of my husband, I might think of my daughter, I might think about one of my sisters or brothers. I've got, in my own case, quite a number of people I can choose from. Here's the fact: the law automatically recognises one of them as the person who can speak on my behalf. Automatically. And I might think, well, my sister would be better than my brother. But in advance, the law has already chosen one of those people. So I better know who that is. I better know who the automatic appointment is. If I've gone and got those forms off the web, and which say, I don't know, something like enduring power of medical attorney, or look, it depends on where you live in Australia what the form is. But if I've pulled off one of those forms and I've worked out who it is and I've appointed this person as with my medical power of attorney, and the documents all properly signed and witnessed and all of that, well, that's who the law will automatically say the doctor's got to talk to that person. But of course, in my own case, I haven't done that at all. I haven't bothered to. And I don't anticipate doing it in my own case either. Lots of people do. And when they've done it, then it's clear who the law says the doctors have to talk to. But even in that case, say I had appointed such a person, that's not enough, just appointing the person, just saying it's got to be so and so. I need to give that person a bit of help. So whether I've appointed someone formally myself, or whether the law will just recognise my husband or my daughter or whoever it is, whatever, I need to give that person a bit of help, because that person is going to find it hard. But let's say that I pluck up the courage and I work out who I want the doctors to talk to. Then I've really got to ask that person to sit down with me and to have a bit of a think about how they'd act in those circumstances. I've done a lot of thinking about how I would help that person, and realised that that's easier said than done. What on earth am I going to say? Helping that person is easier to say than to do. And I think that's recognition of the difficulty of the challenges is why Catholic Health Australia has prepared this new document. Because what it's meant to do is to help me with that conversation. And so the document says that I might say to this person, let's imagine it's my husband, when I'm ill and I'm unable to make my own decisions, the following things would be important to me. And then what the document does, it suggests some things that I might say. Time with my family, the needs of my family, respect for my culture. Well, time with my family will be absolutely critical to me. I imagine that it will be the most important thing. It will be very important to me that the needs of my family are also taken into consideration, because it may be that they are greatly burdened by looking after me. And it may be that my family have their own family responsibilities that they need to undertake too. So it will be important to me, in whatever decisions are made, that the decisions reflect not only what's good for me, but what's best for my family, what works for them. That'll be very important. The needs of my culture, I don't think that will be so important to me. But I can imagine lots of people that I've dealt with whose cultural context is such that it's very important. So that will be something that they'll need, that they should talk with the person about. And then the document says, look, in addition to basic care, including ordinarily the provision of food and water, the following care would be important to me. And again, it gives me some examples: effective pain relief and being kept comfortable. Well, I certainly know that when I have this discussion, I'll be saying to my husband, I know that I anticipate now that I will want to be kept comfortable. Now, I don't think he will need being reminded of that, but nonetheless, for someone who's struggling with having this conversation, struggling with working out what to say, that's a good little prompt, I think. Effective pain relief and being kept comfortable. And then it goes on, this is a good one, treatments I wouldn't want, and again it gives me some examples. Distressing treatments that offer little benefit. Excessive or distressing attempts to resuscitate. Culturally or religiously inappropriate treatment. Well, certainly excessive or distressing attempts to resuscitate, that's certainly one that I think is a very important one to advert to, because the literature is such that there's an enormous amount of unwise, unkind, inappropriate attempts to resuscitate people in hospital. Now, of course, a young person who's been in a car accident, who's had emergency surgery, whose heart suddenly stops, of course you'd go in and you'll try and resuscitate that person there. But mostly resuscitation is attempted on people who are in the very last part of their lives. and it can often be a very unkind and unwise thing to attempt. So that's something that I should talk to, that I should talk about. I think I want to say, now look, don't feel that you have to tell the doctors that if there's even the slightest chance of prolonging my life, they've got to do it by way of resuscitation. Not at all, not at all. I think that this new document from Catholic Health Australia is a very useful one, because what it does is it reminds me that this scenario is likely to happen. It's likely to be the case that doctors will have to make treatment decisions for me without being able to talk them over with me. That's likely to happen. They therefore need to be able to talk to someone, to collaborate with someone, and that better be someone who knows me and who they can trust. So it's important there's someone the doctors can talk to. It's important that that person is the person the law actually automatically says the doctors should talk to. So I better make sure that whoever the law says the doctors have to talk to is exactly the person I want the doctors to talk to. And then what this document does is it helps me help that person. And I think that we can say now that because it is so likely that someone is going to have to undertake that quite difficult task on my behalf, I've got a real responsibility to give that person as much help as I can now. The way we can best help people is to ensure that those conversations can take place. We have to do everything that we can to support those conversations, to support the doctor and the family member, it'll often be a family member, have the right kinds of conversations. And we should resist any alternative which is bureaucratic. We should resist any of these new ways of trying to plan for this circumstance that are kind of tick-a-box approaches. You know, those documents that ask people to write down what they would and wouldn't want. It's such an undesirable way to go. It distracts the doctor from finding the right person with whom to have the conversation and keeping the conversation going. So in our Catholic hospitals, we encourage doctors to be very clear about the specific goal they're trying to achieve in providing the treatment that they're providing, and then to be thoughtful and reflective about which is the most appropriate means for achieving that goal, be it cure or stabilisation or pain relief or improving the way the person dies. There'll often be a range of possible means that you can take towards achieving that goal. So our advanced care plan is meant to encourage people to have the right kinds of conversations about those things, about the proper goal of treatment and about the most appropriate means for achieving that goal. There's the person she's trusted to make those decisions about her life and health on her own part. So you've got a relationship between a doctor with her knowledge and expertise and experience and the person, the trusted representative, who's trying to ensure that wise decisions are made. And it's that collaboration that this new advanced care planning document is meant to support. If I think of the conversations about death in my own family, we're not good at it. We're hopeless. We don't want to anticipate it. And there's something very mysterious about that, and there's something right about it. But there's something else which is wrong about it. There's a kind of cultural pushing it away. There's a kind of reluctance to accept old age, let alone mortality. And that reluctance, that kind of cultural reluctance, seems to me to be one of the things that makes this whole area of medicine and nursing more difficult for even very good and very experienced doctors and nurses, who, by the way, are themselves ordinary human beings with their own reluctance to face up to old age and mortality.